I want to introduce Dr. Wendy Chung, who's Chief of Pediatrics at Boston Children's and at Harvard University. And Wendy, we're going to chat. So, you know, in my line of work, I deal with a lot of smart scientists, and I deal with a lot of capable clinicians, but occasionally I run into somebody really smart, and occasionally I run into a really high-quality clinician, and very rarely I run into a really smart, top-quality scientist, a great clinician who also is a great human being. And I met Wendy when I started n-Lorem. I hadn't met her before, at 6, at the end of her day. That's when you meet with Wendy. And I thought, wow, she's really smart. And I knew she was a great clinician. And what I didn't know, but learned, is that she could talk about her patients as though she were a loving aunt of the patient, and that was every patient. And then I met her team, and it's a team that is caring, I suppose. And so Wendy, then I went through, I don't remember the conversation that well, Wendy, but maybe you do. Probably not. It's probably less memorable for you. But I went through with Wendy what I was doing, and Wendy immediately agreed to be supportive. And she led the way at Columbia along with Neil and Jen Bain, and Columbia has been among our most productive early adopter clinical programs. And so Wendy, welcome. Thank you so much.
Thank you.
So I guess the first thing I want to ask is, I walk into your office and I talk to you about n-Lorem. How crazy did you think I was?
Oh, you're no crazier than I am. So I think we both have the same passion and the same vision for being able to start with one patient. I have a saying, which I know you think about as well. It always starts with the patient and ends with the patient. And we always, both of us, I think, always listen to our patients and learn, and we're not afraid to do something a little bit wild and crazy and learn and iterate as we go forward. And so I've been watching you do it in n-Lorem, and it's been great to see and be a little part of it. And in the same way, as you do that, I do some wild and crazy things as well, knowing that we will have n-Lorem as part of the solution in terms of being able to offer therapies, even for a single person. But I think, like you do, about what the next step in this is going to be. And I'm optimistic. And I think this meeting is so energizing for that optimism to see the path going forward.
Yeah, I agree with all that. And in a video on Susanna, Wendy said, you know, she's 1 in a million or 1 in 10 million, but that doesn't mean she should be left behind. And I think that's the other theme that Wendy and I share, which is no patient should be left behind.
Yep, so that's absolutely true. I guess the other thing that I've realized, and Stan and I haven't talked about this in depth, but the other part of the formula within this is just getting to the starting line and getting a diagnosis. And it all starts with that. If you don't have a diagnosis, you can't be part of this larger program. And so to synergize and intercalate with this, and some people have said it before, it's having a diagnosis and it's having the diagnosis as early as possible. And so just to say this out loud, because I know most of you haven't heard about this, but we've been working synergistically on a program called Guardian, Genomic Uniform Screening Against Rare Diseases in all newborns. Let me underscore all newborns, because I really do believe that every child deserves the equal chance to be able to start out life, to have this information if they want it, if their parents want it. But to be able to prepare them for opportunities when these types of treatments are going to be most effective. And so it is happening, it is working, and most parents actually want this information. And I do think it's going to, just like we did the pilot studies for SMA, to be able to work with Biogen, to be able to show that those ASOs were very effective in those newborns screened. I can see this going very quickly. That's my hope, is to go very quickly so the next generation of children are going to be able to benefit from the types of therapies we've been talking about.
Yeah, you just published the first paper from that study, right?
Yep, the first paper came out last week in JAMA, Journal of American Medical Association, and I think it's the first important step going forward, but we need to continue to figure out how to work out all the kinks in the system. And importantly, it does newborn screening as an infrastructure. Those little heel sticks where we collect a few drops of blood could be what enables and powers this type of next generation that we're talking about.
Yeah, and so, and is that whole genome sequencing or exome sequencing or what exactly?
Yep. So just a little bit more detail. What we did is we took the same dried blood spot that babies were getting anyway for their PKU screening. We did whole genome sequencing so that we'd have infinite flexibility, knowing that we were waiting for each condition to be able to have a treatment. As each condition is treatable, we can then unmask that information and be able to rapidly put it into production. So this is like I said, this is an enabling technology that theoretically could prepare for that next generation, treatment by treatment, even though these conditions are individually rare, collectively, they are so common.
You know, we don't know. So yesterday I spoke about the need to have every newborn born around the world sequenced. And that actually it's happening in the UAE, it's happening in the UK, it's happening in Singapore, and we need to make it happen in the US. And to do that, I think we need hard data to say that it's cost effective, it saves money. And the Undiagnosed Disease Network has been making that the case that diagnosis saves money. Yep. Never mind the heartache, diagnosis saves money. And this is, of course, the most rapid way to make a genetic diagnosis. And so the Guardian data become at least a major component of making the cost effectiveness argument, right?
Yep. Absolutely. The other thing about Guardian, which we've been realizing, is that what we thought was the prevalence in the population is probably off by even an order of magnitude, or in some cases maybe even more. And so for each of you that are representing your rare conditions, it's basically fuel in terms of whoever is thinking about this, whether it's from a public health point of view, whether it's from investors, whether it's through companies thinking about this. All of a sudden these conditions are much more common. So there are more people that we can help with this as we're going forward. So hopefully this again helps sort of all the tide that helps all the boats float, all of the rare disease community to be effective in advocacy.
Yeah, it's really important, and it's the Guardian study in JAMA. It is something that all of you should know about, and you should use to speak to your congressman. You know, if you can find a sane congressman these days, and to your friends, and to your colleagues, and to the medical establishment that you deal with, that it is essential. And we need to move now. And there's no reason not to move, right? And the other piece of that spear, the sharp end of that spear, is the other half of the argument. And the argument that you hear when you talk about diagnosis is, what's the point if you can't do anything about it? You can't make that argument anymore. n-Lorem already exists. We're already showing it can be done. And so you couple the work that Wendy's done with the work that we're doing, and now you have an irrefutable argument to introduce genomic sequencing into all newborns.
And that's exactly what we were thinking. There's, I won't go into all the details, but I try and be forward thinking about what we're going to need for the next 5 or 10 years. So I do think, just to be clear, we do need to gather evidence. We need to be rigorous and have the data to support anything, especially in terms of very big policy decisions that get made behind this. But as we do this, we do need to think about these go back and forth. They are yoked together inextricably: diagnosis and treatment, treatment and diagnosis. And so if we wait for one for the other, we're going to lose a generation. And so we've got to get there faster. And if we can do this for all of you who have children or loved ones, again, this ends up helping your child, your loved one as well, because this is showing in terms of just how frequent it is and how many people can be helped with this.
So does the Guardian database allow you to unblind to, are your data collected in a patient identifiable fashion, I guess?
Right. So all the children, we're, as you can imagine, quite careful about the privacy of these little babies that are going to be growing up, and we want to make sure that this isn't something that someone can use against them at some point. So we have this all locked down in a research database, but we also want to follow over time, because we're only looking at, even though we do whole genome sequencing, we're only looking at a subset of those genes and that information. But over time, we will see how those children do and how they grow up. And one of the reasons I did whole genome sequencing is those children, if they become symptomatic for something we didn't screen for, those parents can come back and have that data reanalyzed within the context of their new medical problem. So that shortens the time to diagnosis for those, even if it wasn't something that we included in the original screen. And so for that reason, everything is individually identifiable, so that if a family needs to go back to their child's data, we know exactly who that is for their child.
You know, one of the things I discovered, which I hadn't thought about until n-Lorem, is that there are all these whole genome sequence databases, and they're enormous, and they're, you know, all over the place, the UK, here, everywhere. But what's absent is the ability to couple the genome to a phenotype in a patient identifiable way, so you can use that information. And the future of epidemiology, in my view, is not to repeat, you know, the Fitman campaign of the 1940s. It's to do genomic sequencing and couple that to all the various omic platforms that we have and follow patients over their lives and that sort of thing. We've got a long way to go before that happens, but at least this is a step that gets us moving in that direction.
Yeah. I think there are a lot of opportunities once we do this portion of it. I think one of the things we'd like to hear from you as families is, what else would, if this were your child, what else would you want to do with that data? What would you want to be part of in terms of that next generation of research? And I think there are opportunities for kids. I will say kids are being left behind when it comes to a lot of the research being done in the United States for reasons I could get on a soapbox and explain, but you as families need to be able to advocate for your kids, because they're not voting, but you are. And so as we're doing it, there are opportunities to use this next generation and studies like Guardian to be able to address a lot of those questions.
Yeah. So, I mean, the first step in determining whether we can help a patient is sequencing. And sequencing is step 1A. You also have to really understand the nature of the mutation. You have to have the cells available. There's a bunch of stuff that needs to happen. And of course, you have now lots of experience doing that for lots of reasons, including n-Lorem. Maybe just walk people through all those sort of intermediate steps. Wendy.
Sure. So just for the families, you've heard about it, but it may not have totally made sense. You'd think that you've got your genetic test report and you should be done. And in fact, that's the first step in terms of understanding what the gene is and making sure that gene is really the answer. And for us, we try and think through, as you've been hearing about, how that genetic variant actually causes the dysfunction. Sometimes we know, sometimes we have to do more hard work to figure that out. But as you've been hearing about, oftentimes those ASOs are not targeting that exact mutation that's in the genetic test report. Oftentimes we need to know about other information that's not in the test report, so there's more sequencing to be done. And so we're not doing that just for giggles. We do that because we might, I call them handles, but we might have other genetic variants that are grabbing, the ASOs are grabbing onto or actually doing their magic on. And so there's sometimes a process by going through and getting yet more sequencing data that then powers this. As you've heard, sometimes there are even mistakes in the sequencing data, so sometimes it's a check and double check in terms of a lot of hard work that goes on based on that. And then as you've also heard, we want to be able to take cells from your child to make sure that we're seeing in a dish what the appropriate response should be from those ASOs. So before we expose any child, any person to something, we want to make sure we've done as much as we can in preparation for that to be both safe and effective. So I know there's a lot of back and forth that goes through this, and you're like, why are you bugging me again? Didn't I give something? And why is this additional blood sample? And it's just a pain. But that's why we're doing it, is we're trying to do all of these things as double and triple checks to go forward, and it takes time. And then the other thing I want to emphasize, which some of you have been hearing through this, is that we also need to have that run-in data, or that data before we get to the point of using the ASO. And we don't always know. I have to admit, with Susanna, there were ways that she changed, her body changed, her brain changed, that I didn't anticipate. And so even though we'd had specific pre-specified endpoints that we'd been collecting very rigorously, Luke and Sally, her parents, were just great at collecting those data. We were also just very careful observers. I literally would be on the video watching her to be able to see what was happening with her on a day-to-day basis. And in a wonderfully remarkable way, certain things changed for her that I could not have anticipated. And so as you start, if you start going through this process, you may be annoyed with some of us that are checking in way too often because you're seeing things that we want to be able to see and quantify. And within this quantification, this being able to measure very accurately and determine that sensitivity, whether or not something's changing and in what way it's changing, is incredibly important to us. We don't want to throw out anything that we shouldn't. So an ASO that might be doing something, we don't want to throw away and discard. So we need to have really reliable data that, like I said, I call it data density. It needs to be dense enough that we can see how it's changing. And I'll say that one of the things that I knew for a long time, but Susanna really taught me, is that when we bring individuals into our medical centers and do some of the things that we do, sometimes people don't have a great day. They didn't get a great night's sleep before in a funny hotel room, or they just woke up on the wrong side of the bed. And that data point may actually not be reflective of what their real life is like. And so actually getting information where people are just having a regular day and in their natural environment, I actually think is going to be at least as important, or sometimes even more important, than what we're doing in clinical centers. And so increasingly many of us are trying to be able to get different ways of assessing how the person's day is on a daily basis to be able to have that sensitivity to change. But what I get really excited about is some of the things you've been hearing about. And so I dream big. I think big in terms of, as we're doing not just one person, but how do we go from the ones to the twos to the dozens to the whatever the number is. But it's very exciting to now be able to have that dream.
You bet. It's quite a dream. And I think when I started n-Lorem, I'd spent all my career developing drugs for populations. And in that, you tend to dismiss anecdotal information. We all do. And one of the big lessons that I've learned, and I've learned a lot, is that done properly, caregiver, parent, or patient information actually adds really important information that you cannot get from standardized instruments. And you know, it's just, we're learning, and as we learn this, of course, then that can be applied to the larger populations. Not only applied to larger populations, but we can teach regulators that there is a way to use this information to approve drugs. And it's been something that the industry and the FDA and everyone who cares has wrestled with for decades, and there has never been a way to actually provide data to solve it. And n-Lorem is doing that.
Yeah, I agree completely. I also want to give you some reassurance. The FDA is listening to you. And so your voices can be heard in the rare disease community. They want to understand how your lives are impacted. They want to understand what's important in terms of what's a meaningful difference. And what's meaningful to you is all that matters at the end of the day, you and your family member. So get activated and make sure your voice is heard.
You know, Tayson being able to put his socks on sounds so trivial, but not to Tayson, and not to Paul, and not to Andrea. And so we are learning ways to take advantage of patient experience to teach us the things that are important that we have dismissed for decades. And another thing that I've been talking about for quite a while, Wendy, is of course it's known that you can have the same mutation and display a different phenotype. It's known. And as I say when I show those tables of mutations and phenotype differences and so on, there's nothing surprising here. It's not shocking. But for the first time in a non-disease bias way in this cross-section of patients with the rarest of mutations, we're accumulating hard data saying there are differences in phenotype even though you have the exact same mutation. And that now is actionable because we have the patient, we have a drug that can change that, we can look at it in cells and ask what phenotype changes, and we can begin to sort out the interdicting factors that drive phenotype differences, and that will teach us about how biology works.
Yeah. Yeah, people are complicated is kind of the bottom line, and within this, I do think, and I'll say one other thing, the other reason, n-Lorem is so careful is just making sure that there is what I'll call the driver, the gene and the variant that is driving, the problem, because it would be a bad thing to think you should be shooting over here and miss entirely that there's something else going on over here that's actually the main driver of the problem. So that being so careful and fastidious is part of why we have a lot of trust in the team with you.
It's and to understand all of the proximal molecular pathologic causes of the symptoms actually is a lot of work. And as we do, though, we can confirm or not that an ASO corrects it all or part of it, and we can then ask the right questions about what parts are corrected. Well, we're going to run out of time, but I do want to talk about your decision to move to Harvard. And of course, when you called me and said you were leaving Columbia, my day went bad. And then you said you were going to be head of pediatrics at Harvard, and I thought, well, that's great, but I know Harvard has earned the right to be Harvard, and it is Harvard in every sense of the word. And so, of course, we were fortunate to have Jen to step in and take over what you would have been doing. But I'm wondering how it's been at Harvard to move the Harvard bureaucracy toward being more energetically committed to doing what we're doing.
Yeah.
And you don't need to show the bruises.
No.
Just keep those to yourself.
Anyway, it's been wonderful, truly, to be here in Boston, to be able to, I think this is true, and no offense to other parts of the world, there's just incredible density, is the way I'll describe it, in terms of good people, good clinicians, good scientists, just good people with hearts of gold in terms, especially at Children's, that care so much about kids. But it's that ecosystem between Mass General, the Brigham, the Broad, and here in Cambridge, a lot of smart folks in the industry and biotech as well. And so it was really, that was the reason I came here personally, exactly at this time when I thought we'd have this ability to go from diagnosis to treatment and to be able to catalyze and enable that. And I thought we needed some leadership in terms of people who had the vision to be able to help guide large institutions. And so leap of faith for me in doing that, but it's been fun to do, and I think I'm having an influence in a positive direction. Within this, there's time takes, especially large institutions like Harvard and Boston Children's Hospital take time to change. And so everything can't happen overnight. But on the other hand, I think there is excitement, enthusiasm about the opportunities for treatments for genetic conditions going forward. And so for some, I think it's ASO is going to be the final. In some, I think ASOs will be a bridge until other things can happen as well. But as we go forward, I do think there's going to be a lot of tools in the toolbox, but we've got to work together and be able to realize these. And there are a lot of levers to pull to do these, but I'm glad to be able to have me as one of those levers, Stan as one of those levers, and you as another one of those levers.
Yeah. So we're in Cambridge here, where if you happen to trip and fall on the sidewalk, at least 5 Nobel laureates will pick you up. Here's an important tip. Should you ever, for example, have a swallowing accident and need somebody to do a Valsalva, don't do it in a room with a whole bunch of physicians, because everybody will look at each other and hope that they do it. But in Cambridge, at least, you can be cared for by a Nobel laureate somewhere along the way. And so it's good to have you in Boston, Wendy, and thank you very much for joining us. And most of all, I thank Wendy for helping us get n-Lorem off and running. Couldn't have done it without you, Wendy. Thanks.